Okay, I see a lot of wine, coffee, and chocolate here, so we're going to talk about what happens if you keep doing this, what might happen to you. So I'm going to spend the next 20 minutes or so kind of talking to you a little bit about Barrett's esophagus. And Barrett's esophagus was originally diagnosed or described by a surgeon, Norman Barrett, Mr. Norman Barrett, that's what they call surgeons in England. And he noticed that a lot of the people he operated on, with cancer or, who had also had reflux, he noticed a change in the lining of the esophagus to sort of the salmon color. And of course, once fiber optic endoscopy began to become widely available in 1957, this finding was increasingly observed. But really for the first 50 years of Barrett's esophagus, we knew very little. Someone actually asked here, what's the risk of Barrett's esophagus? Well, as recently as about 12 years ago, we actually couldn't even give you a good answer for that. So most everything we know about this disease is really in the last 10 years, and I'm almost certain that unless you've been sort of following this disease closely, you're probably going to learn several things about this that you didn't know. And I'm particularly glad to be speaking to a group of primary care physicians tonight because really I think that you will be the vanguard of sort of how we approach and diagnose and manage this disease, not gastroenterologists as we go forward, as I'm going to show you the rationale for that. So we'll talk a little bit about the definition and prevalence. We'll talk about risk of progression, which was asked earlier. We'll talk about screening. Who should you screen and what's the utility of screening? We'll talk about what we currently do now once you have Barrett's, surveillance endoscopy. How good is that? Does it really protect you against developing cancer? In the past, we really didn't have any real options to treat this, and we'll talk about what we have right now. And then we'll talk really about what the current recommendations are and maybe where we're going to be in 10 or 15 years. Okay? So the definition of Barrett's esophagus, really, again, this is what Norman Barrett originally described, I think this point, yeah, is this sort of salmon-colored mucosa that extends above where the end of the folds are. So this is stomach, that's the folds. Where that ends is the tubular esophagus, and this is what you typically call a region of Barrett's. But again, Barrett's is something that actually is not, you can't diagnose it by vision, you have to look under the microscope. So you can suspect it, and you can take a biopsy from that area. But it's not until the biopsy comes back, and you can see it again, the end of the folds versus the squamocolumnar junction, but it's really under the microscope where you sort of see these goblet cells, or these dark cells here, this intestinal metaplasia. That's how you confirm it. So Barrett's can't be sort of diagnosed with a endoscopy. It can only be suggested, and the biopsies are what confirm it, okay? Now, one of the things, and this is something I give to my endoscopist colleagues a lot, but it's actually important for you because you get these reports and you may have to interpret them based on what the endoscopist sort of said. So for Barrett's, essentially you have the diaphragm, so this is where the diaphragm runs across, and then if there's no evidence of a hernia, that's where the stomach and esophagus junction is. And then we have often a whole circumferential area and then sometimes little projections that stick up, and it's this top all the way down to here that is described as the total length of the Barrett's. And that's actually important because we just learned in the last couple of years that the longer the Barrett's, the greater the risk for potentially developing cancer. Okay, and I'll go into that more in a little bit. So this is an area that can get confusing sometimes because sometimes a little bit of the stomach can come up and people might say, well, there's the opening of the diaphragm, there's the end of the folds, and all this is Barrett's. But some people will say it's from here to here is Barrett's. So you have to kind of know your anatomy. This is really your gastroenterologist's job, but they need to report this accurately because if you could falsely make something look longer than it is if you don't have your markers right, and that could potentially make you tell the patient they're at greater risk than they may be, okay? So again, it's important to know where the top of the folds are and in terms of measurement. So again, the 4 measurements that most of your endoscopy reports have, and I'm almost certain that this will become a quality metric within the next 10 years, is you should, when you have a Barrett's patient, describe where the diaphragm is, where the end of the folds are, where the top of the circumferential Barrett's is, and where the top of the total length of Barrett's is. And there's actually these criteria now that are trying to get endoscopists to put all these things down so that when you read a report, you can get an accurate idea of exactly what it looks like without having to look at a picture, okay? So here's a patient who has an area of Barrett's that's 4 centimeters from the end of the folds to here, with an additional 1 centimeter here, okay? So these are some of the things in our world that we're doing to sort of try to improve our ability to communicate and provide more effective reports. Now, how often does it occur? Well, on average, if you just wanted a good ballpark number, say 1%, which means in the United States, there's probably around 3 million people that may have Barrett's esophagus, okay? In GI select populations, how about people with heartburn? The studies suggest 6 to 20% of patients undergoing endoscopy for heartburn will have Barrett's esophagus. There was one study in a higher risk population, sort of a veterans population, a lot of older Caucasian males who we know are at higher risk. Up to 1 in 4 of those patients who ended up getting an endoscopy while they were coming in for their screening colon were found to have Barrett's esophagus, okay? And why do we care? Because even though there may only be about, somewhere in the range of 1% of the population with this, esophageal adenocarcinoma has been rising dramatically. We've made actually some effects in terms of colon cancer. You can actually see we're actually slowly going down our effects with screening colonoscopy, but we see that esophageal adenocarcinoma is sort of skyrocketing in the Western world. And this is data from the United States, but basically this is the same for Europe, same for Australia, much of the developed world, probably due to issues of diet, obesity, other things that are playing a role and that you've heard about earlier. So now I'll go to the second issue. Okay, fine, it's adenocarcinoma of the esophagus is bad. We know that once you develop adenocarcinoma, the average survival is about 15 to 20% over 5 years. So that's one of the worst in terms of cancers. So the question is, if we know about Barrett's, what's the level of risk and when should we intervene? So normally the progression is you go from Barrett's to low grade to high grade to cancer, but it doesn't always go sequentially. You have some people who just go Barrett's to cancer or low grade all the way to cancer without necessarily progressing through high grade, at least that we know of. So if you've got high grade dysplasia, you've got anywhere between a 6 and 10% chance of developing a cancer within the next year. So you could say a 5-year risk of developing cancer is 30 to 50%. In 2013, nobody should be undergoing surveillance for high-grade dysplasia. Okay, that is not standard of care at this time. Okay, 10 years ago, you could either continue biopsying them every 3 months or send them to surgery. Right now, I'll show you what's currently endoscopic ablation is usually considered first-line therapy. But if a patient wants surgery because they just want to have a one-time definitive procedure, that's acceptable too. Most patients would much rather have an endoscopic treatment, but to each its own. But essentially, it is a significant risk. Most studies suggest that it's at least 6% per year, if not higher. And in fact, probably the best study, which I participated in, this was published as a randomized trial, it was published in the New England Journal. We had a very rigorous biopsy protocol, and the 1-year progression, probably much higher than what would typically done in practice. We found in our study that the high-grade arm that was in the sham treatment arm progressed to 19% of those patients developed cancer in just 1 year. So the point I'm trying to make is high grade should get your attention. It should be treated either endoscopically or surgically if a patient does not want repeated procedures. What about low-grade dysplasia? Well, there's kind of been a wide range of what low-grade can give you. Some studies have suggested 2 to 3% per year. One study suggested 13%, but another study suggested it was only 1.7% to cancer per year. So these are kind of pretty disparate numbers over a 5-year period. It's either as low as 10% or as high as 60%. So what do you make of that? It's hard to tell patients. We've now had some more recent data, though, to sort of really give us better information and better done studies. A recent study suggested that the patients it's about 0.5% to cancer in a given year, but about 1.6% to high grade. So overall, about a 2% risk of progression to something worse. Several studies have shown that the risk may even be higher than that when you very selectively pick the patients with true low grade. The problem is pathologists get confused when there's inflammation. So we heard Dr. Albertson talk a little bit about should you biopsy when there's inflammation or not. And if you biopsy and the tissue looks a little bit abnormal, it's hard for the pathologist to sort of say, is that just inflammatory or is there actually some early dysplastic change? In general, in our field, it's recommended that we try to not biopsy in inflamed situations just because somebody might call this. We'd rather heal the inflammation and biopsy when it's not inflamed to get a truer sense of what's going on. But if you exclude the people who have inflammation and have an expert pathologist really get two people to agree that this is really low grade, the study suggests the risk of progressing to cancer or high-grade dysplasia is about 13% per year. And in the New England Journal study that, again, looked at it very rigorously, the progression in the low-grade arm was 13% as well. So I would argue most patients with low-grade dysplasia probably are overcalled because they have inflammation. But if you can get two pathologists to agree that it's low-grade dysplasia, I think that's a lesion that has significant potential. And in our practice, we typically treat those patients. The bigger issue, though, is patients who don't have any dysplasia. They just have Barrett's. And so the question is, how do you manage them? This is really the lion's share of patients that you're probably seeing in your own practices. And the numbers again here have sort of moved around a little bit. Initially, we actually felt good because we actually thought we were getting two studies to agree with each other. Those two studies suggested that it was about 0.5% per year, and for years, that was the number that was thrown around. But recently, there's been a couple of high-profile studies. This was published in the New England Journal from Denmark. This is a very large study that came from Ireland. And they both suggested that the risk might be actually only 1/4. It's only 0.1% per year. And have made people say, well, gee, what's the big risk with this? Do we really need to do anything? This other study was in a U.S. population, which suggested that it's about 0.3% per year. So the more recent thinking is that Barrett's may not be quite as risky as non-dysplastic Barrett's may not be quite as risky as the 0.5%. These authors actually did a study showing, though, that increased length predicts increased risk. So in patients with 1 or 2 centimeters, the risk was about 0.1%, which is similar to the European data, which interestingly, most of those patients had very short segments. And if you take a look at patients with longer segments, 6 centimeters or more, the risk was really 0.5 to 0.6%. So length matters, and that's why it's important to document these things in terms of accurately describing the landmarks which I described. So you're in your office, a patient comes in and says, well, I've had reflux. How do you figure out who you're going to send to microrema, okay? Are you going to send everybody? What criteria can we use, okay? And classically, this is what's been described. Men over age 50, Caucasian, if you've had long-term reflux symptoms defined as 5 years or more, if you're having nighttime symptoms, if you've known hiatal hernia, if you've got increased BMI, particularly abdominal obesity, if there's tobacco use, or, and I sort of described the abdominal obesity at the end. So really the recommendations are to screen patients who have multiple risk factors. So, I mean, a lot of patients might have 1, maybe 2, but if you've got many, that would be sort of an indication. However, that's based on relatively poor quality evidence. Now, it's important to note that if you do this once, unless the patient develops some alarm symptom like trouble swallowing, or if they're vomiting up blood or something like that, you don't need to keep rescreening these people, okay? So if you've done it, it's sort of a one and done kind of thing if they're stable with regards to symptoms. The yield of repeat endoscopy on these people is less than 1 in 40, okay? So there's not a need to keep testing these people if you've decided to do it. But the problem is that we are doing a lousy job in finding these people, okay? And the majority of patients who, if you take a look at endoscopy data from Olmsted County, Minnesota, about 22.6 out of 100,000 patients were found to have Barrett's. But on autopsy, you see that the number is more than 15 times that high. So we're spending a lot of time doing a lot of endoscopy on this very small number, and while all these people sort of silently pass amongst us without knowing of their diagnosis. The problem is reflux itself is not going to be the answer. 60% of patients who have Barrett's do not have significant reflux symptoms, okay, or heartburn symptoms. And a study in Kaiser looking at patients who were diagnosed with esophageal cancer found that only 23 of those patients had known they'd had Barrett's for 6 months or more. Unfortunately, even in 2013, most patients with esophageal adenocarcinoma show up for the first time with their cancer, usually because they can't swallow, usually with advanced disease, okay? So we're missing all of these people, and really the biggest advance we can really come up with is figuring out a way to how do we find these people. To further sort of emphasize that point, they looked at people who were undergoing colonoscopy and then got an endoscopy, and then they said, well, do you have heartburn symptoms or not? And if you take a look at those who had heartburn, about 8% of them were having some kind of Barrett's. 2.6 had more than 3 centimeters, 5.7 had less than 3. But 5.6% of patients who said, I don't have any heartburn at all, also had Barrett's. And nearly the same percentage of them had short segment Barrett's compared to those with heartburn. There were fewer people who had longer segments when they didn't have reflux. So this may be the key. We're actually very excited about this. UCLA is probably going to be one of the first 4 centers in the country to have this, and we probably will have this hopefully within the next year. This is a sponge that tests for something called trefoil factor 3. And this is something that we're not going to do. This is something that ultimately, if it's successful, is something that you will do in your office, similar to what you typically been done with guaiac-based testing in the past. So this comes in a little capsule with a string on it. You're going to tell the patient to swallow this, and then it's going to go down into their stomach. You're going to maybe ask them some other questions or do something else, and then maybe you do your exam. And at the end of this, you're going to pull that string out. When it hits the stomach, this capsule is going to dissolve, and it's going to look like this. You're going to sort of pull this thing straight out, and you're going to send it in and submit it to a testing lab. And it's going to test for this trefoil factor 3. So in England, they did 500 patients, 99% swallowed the sponge, 3% were diagnosed with Barrett's. There's that 3% number again, which I told you about earlier. The sensitivity for even detecting 1 centimeter of Barrett's, which is short segment, was 73%, and it was very specific, which is good, because we don't want to be having a lot of false positives. And then if you take a look at longer segments, 2 centimeters or more, the numbers are better, 90% sensitive, 93% specific. So this may be the way that we use to sort of detect this, because I think we're going to need a population-based screening approach, not something just based on GERD, because that alone is probably going to be insufficient based on the data I've shown you. So let's talk a little bit about what we do right now. We've talked about the issues of why it's hard to sort of find these patients. Once we find them, what do? Well, it's pretty discouraging. We basically have told them that, well, you have a precancerous condition. We're not going to do anything about it. We're just going to wait. The odds are in your favor, and then when you get cancer, we'll go ahead and take your esophagus out, okay? That's the policy. It's ridiculous, okay? And the problem is, it doesn't work. And I'm going to show you why it doesn't work for a variety of reasons. First of all, you take biopsies approximately every 2 centimeters, and you take 4 biopsies per level. It's like mapping floors on a building, okay? And then based upon what level of dysplasia is present, and again, I would argue you should not be doing surveillance on high grade in 2013. That should be being treated in some form. But if you take a look at, this is what you're supposed to be doing. Well, what actually happens, okay? Well, if you take a look at a study at a US pathology lab where they got the report saying how much Barrett's was present, and therefore you could figure out how many biopsies you're supposed to get, they only got the right number of biopsies about half the time, okay? Worse, the longer the segment, the lower the compliance, okay? So somebody's scoping somebody and they go, oh my God, there's all this Barrett's here. They take a couple of biopsies and they come out, okay? So the person who's got the most territory at risk is getting the fewest number of biopsies, okay? That happens both in the United States and in Europe. 2 studies suggest that. And when you get to super long segments, you only have about 30% compliance. But it gets worse, okay? Because this is quite expensive. As I just told you, it only detects cancer. And really the big problem is you're sampling. They've actually done computer volumetric analyses of these esophagus. You're only sampling in most patients around 3 to 5% of the total number of cells in the total area. So if you've got a haystack with 100 straws and you sample 3 and you feel confident that the other 97 are the same as your 3, that's fine. But I would argue that that's probably not the case in many instances. We've also shown you the poor compliance, and I showed you the data from Kaiser. Just published in Gastroenterology, probably the top GI journal in our field, was a larger study from Kaiser Northern California, now looking at nearly 8,500 patients with Barrett's, 300 cancers. 70 patients had a prior diagnosis of Barrett's, 51 had died, and 38 of those had been cancer-related deaths. And they looked at their surveillance history of the people who had the cancer versus who had died of cancer versus those who were living, and they found that basically there was no decreased risk of esophageal cancer death whether you'd had surveillance or not. Okay, so this is kind of hard data, but again, we do a lot of things in medicine we know that sound good but ultimately turn out to be wrong. Okay, and this is another example. Okay, so how do we do a better job? I just told you 3 to 5% of the mucosa is what we're doing. How do we potentially improve this? So how can you feel more confident about what's actually in that haystack? There's a new brush that's sort of come out that may be able to increase your detection of Barrett's epithelium and dysplasia by around 40%. And essentially it sort of, rather than just take a biopsy here, a biopsy here, a biopsy here, a biopsy here, you can sort of go up and down and sample a much larger area and grab the cells. And so this seems to be, again, this is for research at this point primarily, but this may be another technique. We actually have this device, and I found it somewhat useful. I'm not going to play the video here because of some computer issues, but we can actually see real-time microscopy using laser. So you can see squamous cells, Barrett cells, Barrett's with dysplasia, and then frank cancer. So we can actually look at areas and do biopsies right at the time of endoscopy, and then make a decision right then and there as to what we should do. Should we resect this? Should we ablate it? Should we send it to surgery? Versus taking biopsies, waiting a few days, then making a plan, having to do a repeat endoscopy, and so forth. Okay, so the technology now is, as I told you, is very dissatisfying because we really had no way to treat this other than esophagectomy. So if you developed high-grade dysplasia or cancer as recently as about 10 years ago, that's pretty much all we had to offer you. But since then, fortunately, we've had a variety of techniques that have come and have evolved. Some involve sort of endoscopically just actually sucking up the tissue with a band and then cutting out wedges, chunks of it, mucosal resection. And then the rest involve typically destroying the tissue, not necessarily resecting it, but destroying it. And some have been sort of a variety of point and shoot techniques. Some have used laser, some have used radiofrequency energy, and this is the best studied technique, and that's the one I'm going to discuss tonight. Some have used a variety of photosensitizers. Some have actually, rather than burning it, have ablated it by freezing it. And this is a newer technology. We actually primarily do this, but also have this cryotherapy available at UCLA. So I'm just going to briefly go over some of the data. This is essentially the probe. It comes in a variety of sizes. It only burns the top surface without getting in deep, which minimizes the complications of strictures. Again, I'm just going to sort of briefly go over the data here. In general, you can get rid of anywhere between 80 and 90% of all Barrett's tissue, and you can typically get between 90 and 100% of all the dysplasia eradicated. Okay, and that's really all I want you to take away from the slide. But this is not experimental. It's been done over 100,000 times in the United States. There's over 200 papers looking at this technology worldwide. This video is not going to play. I'm sorry about that. One of the questions is, how do you know who this is going to work well on? And I think we've heard sort of combining the issues of GERD and testing of GERD. Really, the risk factors for this primarily are the number of reflux events. The people who have longer segments obviously are going to have more territory to eradicate, so they're going to take longer. And a hiatal hernia is probably sort of a surrogate marker for patients who have difficult to control reflux, and that's also an issue. So the real interesting thing is if you burn the tissue but allow it to grow back in an acid environment, it grows back as Barrett's esophagus. But if you burn it and then allow it to grow back in a non-acid environment with limited reflux, it tends to work much better and it changes into neosquamous tissue. And that's really the main point. It's quite safe. It's been done, as I mentioned, over 100,000 times. And the risk of these procedures is really basically the same as standard endoscopy. It's really not any riskier. In terms of duration of activity, again, the initial studies suggested that at 2 and 3 years, it probably worked about 90. It was lasted about 90% of the time. There's more recent data, 5,000 patients in a community setting, that suggests it may not be quite that high. It may be more in the range of around 80%. But again, most of those patients can be touched up. So it does require some follow-up. You can't just burn it and forget about it. But it is something that certainly is a marked advance over simply watching it. So where does that leave us? What should you be doing? What are the guidelines in 2013? So the American Gastroenterology says that high-grade dysplasia says that endotherapy with some form of ablation or resection is recommended rather than surveillance. And again, for a patient who doesn't want endoscopic therapy, surgery certainly would be an option. For low-grade dysplasia, it should be an option in patients who have confirmed low-grade, and that means 2 pathologists looking at it. And in that situation, I would argue the risk of low-grade dysplasia is significant enough to at least consider ablation with your patients. For non-dysplastic Barrett's, I've showed you some numbers that are not nearly as risky. The society suggests that it should be considered for people at increased risk for progression. Of course, the natural question is, well, who's at increased risk? And I'll come back to that in a minute. Even the surgeons agree. Of course, the GI guys may say that, well, we'd like to do this. But the surgeons have acknowledged that for high-grade intraepithelial neoplasia and intramucosal cancer, it can be managed with these techniques and show a reduction in the development of cancer, and that this can be used to effectively eradicate all levels of Barrett's. And there's actually, I didn't show it to you in the interest of time, there's studies that show equal outcomes and less morbidity in comparing endoscopic therapy to surgical therapy for high-grade dysplasia. So the American Society of GI Endoscopy, again, echoes these things. Ablation should be considered in patients as an alternative to surveillance in patients with confirmed low-grade. High-grade, again, they recommend endoscopic resection or RFA be the option for flat high-grade. Again, for non-dysplastic, they say it should be an option in select patients, particularly those maybe with a family history or some of the other risk factors that are mentioned there, sort of the advanced age, white race, age over 50. So that really leaves us with the elephant in the room. Which of my non-dysplastic patients, of any, should I consider ablation on? And again, there's no clear answer. People say high risk should be reasonable. Probably a family history of cancer, more than 3 centimeters of Barrett's, or someone who's quite young and may have many years of surveillance ahead of them might be an option. Others have suggested poorly controlled GERD, but again, that's a person who's also going to respond poorly to ablation therapy, so it's not clear if that's a good choice. Elevated BMI or men. So I think I'll summarize with sort of where we're at right now. I think the next 15 years, what do we need to know? We need to really figure out a way to screen these patients, figure out where the bottom of the iceberg is. We need to find out which patients with non-dysplastic Barrett's are actually going to progress. Most of them don't, but it would be nice to be able to come up with something, biomarkers from a biopsy or some clinical risk panel that you could say, okay, you don't need surveillance, you're never going to do anything, you're at risk even though you have non-dysplastic, you should be treated. We need to figure out if we are going to do surveillance, how to do that better, to sample more, to do it more efficiently, to increase compliance among endoscopists. We need to better figure out which patients who we do try ablation on are going to be most likely to be successful and why those who don't get a good response fail, and try to correct those risk factors. We'd love to be able to someday tell someone who's been ablated, you know what, you don't need to be followed anymore, you're officially cured. We're unable to do that. Patients who are ablated still require follow-up, although at increasingly infrequent intervals. And then the last, can we ever stop this? Because that really will be the key to making it cost effective. And then one last issue is there a role for chemoprophylaxis? There's a large study in Europe looking at that. So a couple of years ago, I wrote an article about sort of what the future may look like, and this is sort of what our summary was. We would need to come up with something inexpensive and non-invasive, something like that sponge I showed you that was in the saliva or blood, that was highly sensitive in the general population. I think it's going to require general population testing at the primary care level to identify these people. If the test is negative, you're done, no further evaluation. If it's positive, you're going to send him to your friendly gastroenterologist who's going to do an endoscopy to confirm whether it's there or not. If it's there, then hopefully you'll be able to have some kind of a risk stratification panel to put them into one of 3 groups. The low-risk people, you can tell them, forget about it, you don't need any further follow-up. The high-risk group, we treat with one of the technologies I've shown. Or for the intermediate people, maybe we choose something in between like chemoprophylaxis and surveillance. So to conclude, I think, again, we really need a better screening method. Again, we need to come up with better ways to do surveillance because it is certainly limited. I would argue that confirmed Barrett's with dysplasia has a high rate of progression. We do have sort of effective, safe, and durable options now to treat this finally in the last 10 years. And again, the key and the holy grail for this is to figure out in this huge group of patients with non-dysplastic Barrett's who's never going to do anything and who's likely to progress, and be able to accurately predict that. So with that, I'll stop and take any questions. Yeah.
We make the diagnosis of Barrett's, and we, as clinicians, recommend PPIs, hoping they will have an effect in reducing progression. Is there evidence that acid suppression has anything to do with pathophysiology of Barrett's progression?
Yeah, well, the answer to your question is possibly, but the bigger question, and the one we more definitively answer is, it does not have anything to do with regression, okay? So we actually have good data because we have sham-controlled trials in patients in whom Barrett's was present, and we know that basically Barrett's does not regress. So if you say, well, gee, I'm going to treat your Barrett's with a PPI, okay? Well, at most, all you're going to do potentially is go to the issue that you're addressing, Joel, which is maybe you're going to stop someone with 3 centimeters of Barrett's from going to 6 centimeters of Barrett's, okay? Is there any data to suggest that if you're on a PPI versus not, you're less likely to progress, to dysplasia? It's not clear. In fact, the answer is probably no, although there's not a strong trial to answer that question, okay? But we do have pretty strong evidence to suggest that Barrett's doesn't go away with a PPI. Once it's there, unless you do some form of resection or...
Barrett's, do we know for sure that it's an acid-mediated process? I just scoped somewhat, and incidentally we found Barrett's with high-grade dysplasia.
Yeah.
Get upper GI from a gastric ulcer.
Right. Well, this is a favorite, speaking of USC, this is Tom DeMeester's sort of favorite argument, which is that as we increase the PPI use in the United States, the Barrett's use is also going up. So now, is it that those two are truly correlated to the fact that we're also, just having more reflux in general? It's not controlled, people are getting heavier. It's unclear. But it's not clear if it's all refluxate. In fact, you bring up a good point. The risk factor for failed ablation in that study I presented in terms of people who got ablated wasn't necessarily strong acidic. It was actually weakly acidic and mildly basic refluxate. So it may not be just acid, it may be any refluxate that may be causing that.